Yeah, good afternoon, everyone. It's a pleasure to be here with all of you, and thanks to the organizers for having me over here. So I'll be talking about the interpretation of the ROS1 rearrangement in NSCLC. So we know that more than 90% of the lung cancer, they are NSCLC, and the majority of which are adenocarcinoma. And the role of pathologist in this era is not only just to diagnose the lung cancer, but also to find out the driver mutation so that the patient can be put on the targeted therapies. And we know that majority of these common and uncommon driver mutations, they are targetable with the FDA approved agent or something which is in the clinical trials. So we know that the bulk of the driver mutations comprises of EGFR and ALK, but we have to realize that there is a potential application even in the uncommon mutations which is beyond EGFR and ALK, and the very important among that is the ROS1 gene rearrangement. So it's a proto-oncogene. Role of the ROS1 was first identified in the brain tumors 2 decades back, and the role in the lung cancer was reported in 2007 by Rykova et al. The improved sequencing techniques have enabled the discovery of the increasing number of the fusion partners. So this is the bird's eye view of the main ROS1 fusion partners in the ROS1 positive NSCLC, and these top 5 genes partners, you can see that they in totality they comprises of 90% of the ROS1 gene rearrangements. So the fusion protein is they are the oncoproteins that actually stimulates the various downstream pathways leading to tumorigenesis. So the ROS1 rearrangements are frequently associated with the young patients, women, never smokers predominantly, showing the lipidic, acinar, solid or even the mucinous pattern, and they are frequently TTF1 positive, frequently present with the advanced stage, and they have a proclivity even for the brain metastasis. The ROS1 rearrangement, they occur in 1 to 2 to 2.6% of the NSCLC. The accurate determination of the ROS1 gene rearrangement hence offers the patient the opportunity to receive the highly effective targeted therapies with less toxicity. So this was our our departmental data, the publication by Mehta et al., in which 709 patients were taken of stage 4 NSCLC adenocarcinoma, and the frequency was found to be 2.8% for the ROS1 gene rearrangement. So these are the testing modalities, the IHC, FISH and NGS. The IHC is mainly for the screening modality, and 2 popular clones, the clone D4, D6 from cell signaling we are using for last 7 to 8 years, which has actually stood the test of time. And another clone recently introduced by Roche, that is SP384 last year. So IHC, the guidelines recommends the use of IHC only as a screening method, which is a useful, and clones have a very high sensitivity as compared to FISH and NGS. The ROS1 specificity, however, is variable, ranging from 70 to 90% and depends upon the clone used and the positivity threshold applied. But the bottom line is that all the positive immunohistochemistry cases have to be confirmed with the orthogonal testing before starting on the targeted therapy, unlike we do with the ALK, where we straight away proceed with the treatment. So just to share 2-3 cases from the case libraries, this was the NSCLC adenocarcinoma with acinar pattern of growth showing strong and diffuse expression. Subsequently, it was FISH positive. This was another NSCLC adenocarcinoma with a solid pattern of growth. We can see multinucleated tumor giant cells, bizarre cells were there, and it was showing not a diffuse but a heterogeneous ROS1 immunoexpression, which was subsequently FISH positive. Another case with the mucinous and micropapillary pattern of growth showing the strong and diffuse expression of ROS1 IHC, subsequently FISH positive. So IHC has the advantages that it is an effective screening tool and requires just one section, which needs just a 4 micron section. Cell blocks can also be used because many times patient present with the pleural effusion, and that's the only sample we have. And if IHC is negative, we can get away with the subsequent FISH testing because the sensitivity is very high. Another advantage is that we have a short turnaround time, like medical oncologists do get across the clinical situations where we have to expedite the test result, especially like sometimes my colleague Dr. Ullas, he called me that he wants the ALK and ROS1 because he's anticipating that mutation as per the clinical presentation of the patient. So we are able to do it in just 6 hours. So another advantage is that standardization and validation is quite easier and more labs can do the IHC. The disadvantage is that the different interpretation criteria were suggested with a different cutoff. Hence, currently there is no standard cutoff criteria accepted. Thus, it is recommended that each laboratory validate its own interpretative range. There are some practical challenging scenarios in the ROS1 IHC. So first is the false negative IHC results. The patient with the negative IHC results are unlikely to be tested again for this biomarker. Hence, sensitivity is kept high by these clones. So if it is negative, one should consider the overall context of the presentation and one should go for a multi-gene assay, NGS. Another challenging scenario is the false positive ROS1 expression, because significant ROS1 positive immunoexpression can be seen in the ROS1 amplified tumors. So these are amplified, not rearranged. Another entity is the ROS1 negative tumors, which contain other oncogenic drivers, mainly EGFR mutation, also KRAS, BRAF, ALK fusion and HER2 abnormalities. So all positive IHC cases must be confirmed with the orthogonal testing, FISH or NGS. So this is the workflow of the ROS1 IHC interpretation, which I have just explained in my previous slides. So coming to the break apart FISH, it is considered as a gold standard to diagnose the ROS1 gene rearrangements and played a vital role in the initial clinical trials of crizotinib. So we are doing it by using a dual probe break apart design with the two different fluorochromes labeled on either side of the fusion breakpoint 3' and 5' end. So you can see here the orange and the green fluorochrome which is applied on the either side of the breakpoint of the ROS gene. So what is the criteria and prerequisite for a positive test? The criteria for a positive test is that more than 15% of the cells should show a break apart separation of the 3' and 5' probes, or more than 15% of the cells show isolated 3' signal. Whereas the prerequisite for a positive test is that we have to be sure that more than 50 viable tumor cells must be present to validate a positive finding. So this is a negative test. When the ROS1 rearrangement is absent, we can see that there is no break apart and we can see a fused yellow signal. This is the positive test in which we can see the arrows are showing the break apart. The two signals are separated by twice the diameter of the signals. And here this is the atypical pattern which is positive, in which the native ROS1 fusion signal and one isolated 3' signal without the corresponding 5' signal, which is also a positive test. But also you can have a false negative break apart FISH, which is a problem in the ROS1 rearrangement, that certain fusion partners, primarily the GOPC and EZR, which I showed in my previous slides, they are known to cause false negative break apart FISH. The reason is that the deleted region is too small, that leaves enough of the complementary region for the hybridization of both the probes. And another scenario is that for the false negative break apart FISH is that there can be a complex staining pattern in which many atypical fusion doublets are seen, but the percentage of cells with the typical split signals, they are below the cutoff, that is less than 15%. So if the break apart signals are 10 to 15%, less than 15%, an orthogonal testing should be done by NGS before labeling the case as ROS1 negative. And you can also have a false positive break apart FISH because of unproductive rearrangement, which are non-functional ROS1 fusion and also aberrant probe hybridization. Lastly, the NGS, which is a recommended method now and need of hour, that NGS technology consists of massive parallel nucleic acid sequencing and allows the simultaneous molecular characterization of the multiple genes. Both DNA and RNA can be used as the input material for the assays. It allows the detection of the SNVs, insertion, deletions, copy number variation and genomic rearrangements. The advantage of NGS is that it has a potential to detect several fusion, not only the known but also the novel, and to identify the specific partner of translocation. So I'll be winding in 1 minute. So the targeted multiplex panels able to analyze the hotspot region of all the approved molecular biomarkers besides ROS1, and it saves time and histological material in respect to the sequential single targeted test. So this was the slide I initially shown, and you can see that these very less frequent ROS1 fusion partners, they were able to detect only by the NGS techniques. So the DNA based sequencing, because most of the genomic breakpoints that lead to the gene fusion, they occur in the introns. Therefore assays are designed to detect the rearrangement fusion must sequence the introns. However, the introns are difficult. They are known for the frequently containing the repetitive sequences, which are actually difficult to assess by the NGS, which were also alluded to in the previous talks. So there will be a possibility that genomic breakpoints may occur in the intronic region, which cannot be properly sequenced, leading to false negative results. And this is being taken care by the RNA based NGS, which has the advantage over the DNA based NGS, that sequencing is basically focused on the coding sequence instead of introns, hence reduce false negative cases. However, the drawback of this approach is that we have to rely highly on the RNA quality. So this was the example of showing the classical CD74 and ROS1 fusion with a very clean reads in the NGS. So to conclude, ROS1 positive NSCLC has been identified as a distinct molecular class. The effectiveness of the targeted therapies depend on the accurate determination of the genomic status of the tumor, and it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical and post-analytical steps. Thank you so much.